The video demonstrates a mass removal, an inverted nipple. The margin of incision is indicated by the nature of the mass. Benign lumps, the margin is closer as you are just removing the mass. If the mass was malignant and invasive, much larger margins would be needed to prevent spread and regrowth of the mass. An elliptical incision is needed, so when we close the skin will not become dog-eared. Most new graduates either place too little or too much force on the scalpel blade. With this mass, we are just removing the skin with the inverted nipple attached, so a deep incision would result unnecessary muscular damage. We perform the surgery without a Penrose drain because the amount of skin we are removing is small. But if we were to use a Penrose, the circles indicate where the Penrose should exit below the wound. The skin is raised so a full thickness incision could be made without damage to any of the tissues below. Blunt dissection is performed to separate the skin from the soft tissue below. There are two ways this can be done, either using a scalpel blade to follow the elliptical incision line, or if you have razor-sharp scissors, you can surgically cut. They have to be very sharp, otherwise they may result in a crushing injury to the skin and affect healing. So now we have isolated the skin with the interned nipple. We now blunt dissect to separate this part of the skin and ligate any vessels. You can see this vessel, a pulsating artery. So I place a transfixing ligature using 2 metric 3/0 coated multifilament PGA. I am now searching for any more vessels to tie off. I am going cautious with my blunt dissection so I don't damage any hidden vessels. I can't see any more obvious vessels. The ligature was purposely placed on the dog side and not the lumps, so I can just snip this. Now, if we had any bleeders in the actual skin, we could not ligate these, as these would affect edge-to-edge healing. So remember, you must transfix any ligatures, otherwise they will just fall off. This looks like the venous supply to the artery we tied off. so it all looks good for closure. I decided to bring the fat bed together to stop any slow ooze. This is a skin bleeder, which I mentioned earlier. We cannot ligate this, but if we correctly place a subdermal layer, this should stop any bleeding. I position the needle so it should go around the back of the skin vessel, and as we tie our anchor knot, it should effectively stop the bleeding. So the anchor knot is more subdermal than intradermal. To stop the bleeding, I have to tie the knot tighter than normal, which results in some skin tenting. Here you can see the dead space, so it would have been better to use a Penrose drain to prevent any seroma formation. You will see these in other lump removals, but some tacking sutures would have been good. This is where you place a subdermal ligation deeper into the wound and attach it to the fat muscle layer. The wound did heal well without complications. Tacking sutures close the dead space, but also reduce the chance of post-op breakdown, as they take the stress off the skin closure. So we close the subdermal layer with a sergents or an Aberdeen. A good part of a sergents is that you can use the loop to tighten the pattern. You can see I do pull it a little too tight, as there is some concertina of the skin. The needle is passed caudal to the knot, coming out in the intradermal area, thus hiding the knot by pulling it flat. Now we continue with the intradermal suture pattern, finishing with either a surgeon's or Aberdeen. Remember, research does show passing the suture through twice at the end rather than once considerably reduces the chance of an Aberdeen breakdown. You can see now the knot is hidden as the skin comes together and we continue Now you can spot the disaster on closing the intradermal layer. I snapped off the tail, just leaving the loop. Watch what I do to fix this. I have two options. I could cut the loop on one side, close to the knot, and then thread a needle and bury with the loop, or go old school and add interrupted skin sutures and snip the tail off. I went with the second option. I use Vicro Rapid rather than nylon, as this is a charity dog and doesn't like vets. The Rapid will fall out in about 2 weeks. The key to interrupted skin sutures is not to get them too tight, and just bring the skin together. So form the knot loose, as the skin will swell a little post-op. If my suture was smaller, I would have gone 3 throws, followed by 2, and then gently placed 3 to 4 ones loose. and then the final two tight. If you pull your first ones tight, the knot will tighten too much. As at the charity, we only have the large 3.5 metric 0 USP. I have to do a loose double throw, followed by 3 to 4 loose ones. And then the final two ones tight. It's not pretty, but it's strong, and we will not get a wound breakdown, which is the most important factor at the charity.